So you have started with the indications in both DSEK and DMEK, where you should not try DMEK, and you have already mentioned that there are certain indications where we should go for DMEK, but there are certain indications probably in later stage when you are experienced enough, you can try those cases. So this is the course of ours, DMEK Made Simple for the beginners. And you know the difference is obvious. One eye, right eye patient has DSEK and left eye is DMEK. And you know the satisfaction level both for the patients and the doctor, treating doctor, is very, very high. And if you see that DSEK is always 80 to 120 micron more, so it is not perfect anatomically and also visually, we know over a period of time. So DMEK is perfectly anatomical, and there is more chance of getting 20/20 or 20/25 vision and perfectly anatomical. So I will skip some of the slides because I've already made, but this graph is very important. This is US data. US data, you see that 28 data I could not find out if Audrey can tell, but 21 data is there in the website, and you see that gradually over last 10 years, there is from 3.2% to 47% shift towards DMEK by the US domestic surgeon. And you see that again, DSEK is gradually reducing from 21,000. Then its peak was like 2013-14, it was 23,000, now it is 15,000. So DMEK is getting popularity. I believe that in India, 100 plus surgeons are using EK, mostly DSEK, and many people are doing DMEK, and the figure we do not have, but maybe overall EK is 4,000 to 6,000. So I will go quickly, already mentioned by Audrey. I will skip this slide. I will come directly to one of the indication is like some of the contraindications for the beginner, that if it is a total aphakia, large pupil, vitreous in SC, you need a very good vitreoretinal surgeon, those who can fix a scleral fixation or retrofixated IOL, then extensive pass, and otherwise there is visibility is poor. And there are certain contraindications. Even in PBK, we see, you've seen the right side PBK, the corneal thickness is 1500 microns, so you cannot do DSEK in those cases. So DMEK indication in Western world is FECD, 80% cases, the range between 60 to 80%. Pseudophakic corneal edema is like 15 to 20%. And other indication which Audrey has shown us that is around 15%. So this is the overall scenario of Western world. When you come to India, this is from our hospital published. We see little more Fuchs dystrophy in eastern part of the country, and the percentage is around 36%. But other parts where we have discussed among our colleagues, the percentage is 15% and 80% of thing is pseudophakic bullous keratosis. The other indications are there. We do not get many CHD patients. Rajesh has a beautiful series of CHD, but we see a lot of ICE syndrome and post-HSB endothelialitis, and we have published our result. So these are two group of people. Post-PK DSEK we do, but again, all depend upon what Audrey has explained, that thing. Workup is very important. Mostly, I used to maintain an Excel sheet. You used to pre-operative details of all the things, and you need to dilate the people in pseudophakic bullous keratopathy And you need to know what is the lens status, whether it is in the back, in the sulcus, whether it is 3-piece, whether it is single piece IOL, because in multi-piece IOL, if it is in the sulcus fixation, DMEK graft unfolding may be difficult in some of the scenario. And you see the dilatation of the people, you must see the if post-EAC cases, large EAC done, because and post-vitrectomy cases where you do not find and air tends to go behind. So previous glaucoma surgery already discussed, lens status. Then retina status is also important. I believe that there are a situation where you need to know whether vitreous is there in the anterior chamber or the not. And before starting the case, you may put a little bit of triamcinolone in the anterior chamber and check. Or a small bubble, you try to rotate the eyeball and you can see the bubble movement, how it is going. And pre-op investigation like USG, B-scan, axial length for biometry, and there are one-eyed cases, you need to know the spectacle history also, anterior segment photography for documentation. Anterior segment OCT gives good clue about subepithelial scarring. And post-PK cases, you need to see the posterior host graft junction status. Anesthetist clearance and macular OCT is very important. If you have get a scope of doing a macular OCT, especially in PBK cases, that there are a lot of reports are coming, and mostly these are pre-existing. So patient always blame that you see that graft is absolutely clear, still the vision is not coming. And if you see that macular OCT post-op, you will discover there is a chronic CME. Before operation, you have a scope, like mild haziness, you may get pick up. Then at the same time, you can give STK or other intravitreal injection. Then phakic corneal edema, cataract surgery, or no to cataract surgery. In our part, as a rule, in our hospital, we used to do if the patient is 40 years and above, DMEK IOL straightforward. If that less, then we may do in 2 sittings, first DMEK, then later on patient come. But in eye syndrome cases, even in younger age, I used to remove the crystalline lens because you get a little work to play because a lot of synechia is there. So sometimes you need to clear remove the crystalline lens. And cataract surgery after DMEK, it's not difficult, same as like routine cataract. Take extra precaution with cohesive, dispersive viscoelastic. And the surgery, the IOL of choice, like mostly I prefer hydrophobic acrylic, and usually no to YOLO lens if the other eye has got YOLO. Usually no to multifocal. If the other eye has got multifocal or multifocal bullous keratopathy, I did DMEK, then second eye I prefer multifocal because of all this. And toric IOL if the astigmatism is more than 2 or 2.5 diopter, and target usually 0.5 to 0.75 myopia. And this is also important if you have to get a scope of doing specular microscopy of the other eye. You need to know there are a lot of undiagnosed Fuchs is there, and a lot of those patients coming from comprehensive ophthalmologist to your clinic. And it actually shows the patient, yes, there is no fault in the treating doctor, cataract surgeon, it is fault in your eyes. So you can guard your colleague, and it is good practice, so you must practice that. So that is the part of indication, and I will go straight towards the donor preparation. Donor preparation, I know that the first hurdle is donor preparation, and US surgeon, though Audrey is sitting here, 80% of the surgeon used eye bank prepared tissue, and they always say they are spoiled. In fact, EK surgery in US start in their eye bank. pre-steep, pre-stamp, pre-stent, preloaded DMEK graft is available, and they are hugely expensive. In India, I believe that most of the surgeons are preparing their graft. I do not have any knowledge that anybody, any eye bank is preparing and shipping to any other surgeon. But donor damage during graft preparation, what I can understand from discussion of different colleagues, it's between 1 to 4.3%. So different techniques are available. A classical manual peeling technique, stripping, peeling from the trabecular meshwork, peeling after creating a superficial refined cut, scuba technique, pneumatic dissection, hydro dissection, lamellar dissection, etc. But whichever is best on your hand, you do that without damaging the donor. So my simple manual, these are my instrument. I used to prepare donor during my surgery, and all are readily available. And this I always prepare just before donor insertion. So during recipient preparation after inferior PI, I give air tamponade for 5 to 7 minutes because of oozing of blood to prevent those oozing. And it also clears the edematous cornea to some extent. So I get time of 5 to 7 minutes, and those 5 to 7 minutes I used to do the donor preparation. It also saves my time. So this was my classical technique, otherwise 9.5 millimeter partial trepanation, handheld trepanation. And then I used to remove the peripheral DM. And if this sign is, if it comes very easily, that means this graft will behave very good and it peels very easily. So I do use Trefine Blue lot of dot. I do not use BSS. It is under, so it is like this, it's go by one hand technique in one go, little bit hinge at the other end, then do a 3 millimeter punch, reflect back the DM, reverse it, then soak that oil with the sponge. This has to be very meticulous, otherwise there will be smudging of S marking, and then flip it. Normally 8 millimeter graft, and you just remove the peripheral redundant part, take this graft over the corneal stroma, you just stain it for 1 minute, maybe less than 1 minute, take in an injector system, and your thing is ready. This is the other thing I use. This is a 37 years donor cornea. I have used this, not so sharp. It is just kind of like chopper, but tip is little blunt. I try to separate because younger one, this donor DM endothelial edge getting is very difficult. So I try to get once you get the edge, you can go 360 degree without any radial tear. You have to be very careful. One hand, you do not require other hand. You just go slowly, and you just separate the edges from this 360 degree. At least 270 degree, if you do it, then your job is done. Sometime you may get stuck, so you start from the other area. This is younger donor. I have stripped as young as 17 years old, but very difficult to peel them, and sometime donor damage might happen. And this movement is very important. You see that there is side-to-side movement in compared to previous one. This is I practice in younger donor less than 50. So you go up to the just 1 to 2 millimeter hinge, and you see the typical tight cigar-shaped scroll. And we have published our result, and different sizes are mostly 8 millimeter graft, 63% of the cases. Believe me, my more than 1,000 cases, only 7 tissue damaged, and those 7 tissue I have used for other purpose. So once you are accustomed with this, it is the easiest part of just overcoming this hurdle. So we have also given a thought of peripherally trepanated DMEK that means periphery, we know that endothelial cell count is more, and we used our iBank technician to mark 12 o'clock position, to mark, and it was published in, this is almost same, only this difference is when you complete this peeling, you see that you are one side. I purposefully for this study we use superior peripheral, but you may choose any peripheral. Peripheral always gives to, more endothelial cell to your this thing. And if you see that one side it is 1 millimeter and other side it is 3.5 or maybe 4 millimeter. So this is a concept. Those who are doing may try and see their result. And this is my same patient, one eye and other eye. This is 2016, 17. You see the donor density is, post-op density is so much, sometimes so satisfying. And this is another during pandemic. This is doubling the utilization, BCL interface rate. This is again published in this thing. And normally we have this kind of, because we are making a hole of 3 millimeter, but for during pandemic, we need to, the first part is same, but second part, I used to make a BCL, resize BCL, make a hole of the BCL of, that, so that resized is 10.5 or 11 millimeter, and we negotiate that BCL in between stroma and epithelium. This hole actually make for that S mark. So if you go that, it is just to save the, so you make like this. So you negotiate and you soak the thing and you flip the BCL, the stroma remains intact, and you just dry it, put an S mark, and your whole stroma, 9.5 millimeter, is beautifully placed. So this is another, whenever same day posting DALC and DMEK, we used to do, even now, we published our result with 47 cases. I think we have crossed 100 of such cases. Take-home Moses's DMEK graft preparation is not so difficult, require backup tissue for initial few cases. Any media, MK medium, cortisol, optisol, GS, any media you can initially take help from the master, watch YouTube videos. It is always thrilling to do DMEK peeling with some adrenaline rush, and you may need practice and practice. So Rajesh, I'll go for basic steps.
Oh, okay, fine.
Because this is donor preparation, basic steps. I'll skip some of the slide because the basic is again already shown by Audrey. And you know that pre-op preparation is always same, almost same. Subtenon or perivalvular block. You know the difference between DMEK and DSEK already there. So DM scoring need to be little larger, DM scoring in DMEK. And inferior PI mostly mandatory, but many people are reporting differently. So I am also trying that, may not be necessary for all the cases. Anterior chamber should remain shallow during your donor interaction. Graft transfer is easier in most the cases. Unfolding is difficult, so typically the marks helps us in dark brown iris and Indian late presentation cases. Donor centration is easy in DSEK. I am telling you, this is one of the difficult part of DMEK, and everyone has their own trick, but it doesn't play it for all the cases. And never ever try to over-enthusiastic to center it more and more. That is my learning, that you should not over-emphasize. If it is little eccentric, it doesn't matter. And air injection almost just air fill, not overfill. Just air fill is the right terminology for DMEK. and usually flat supine position, 1 to 2 hours, and this may vary from patient to patient. So I am skipping all these because all are done. So the main incision, I always go little bit posterior limbal or maybe posterior scleral, so mostly sutureless is in most of my cases. Then DM scoring, you know that, but inferior PI, you may use both the technique, whichever is available to you, but you must be very careful. Rajesh will also share that with vitrector, you might damage the zonule and vitreous may pop out in some of the cases. I had in one case, so it is very important. And oozing of the blood, immediate air tamponade is very important to this thing. So donors, and this part actually Rajesh will tell everything. He has many kind of this thing. My view, insertion techniques, some techniques are difficult, some are easy. Some techniques may give better in terms of endothelial cell loss. Probably the principle remains same. Choose a technique which is consistent in your hand with good outcome, then master it. So injector, I always use simple, I am skipping that. And this is my usual technique of, mostly I follow same technique again and again and again, mostly, 95% of the cases. So I rotate the graft in horizontal. I always operate from superior head end of the patient because of some, this is, you see that the S is reverse. So here you have to give a little, gush of BSS, not heavily, so that it rotates automatically. Then you are perfectly at the central position, and then you make it center. I do not put any suture in the main dune in 99% cases. And when you know that it is center, then you give air, try with little air, and try to see your S is right or not. And when you are right, then you may give little more air so that, and you see that S is right. So immediate care is very important. Keep the patient in the recovery room, maintain supine position. This is my practice. Examine under slit lamp. In sitting posture, you see where is the air bubble. If it's just above the inferior PI, you are just fine. Ask the patient to shift into the ward for again 4-6 hours. If it is not, it is PI is covered by the air, little burping of air from one of the side port by 30 gauge needle or McPherson forceps, immediately you find that there is an air level and you are sure that there will be no pupillary block glaucoma. Earlier we used to keep the patient overnight. In pre-pandemic day, we have, because of pandemic situation, we have changed our whole system and there is no overnight, so we usually discharge the patient after 4 to 6 hours.